Hello everyone, this is Dr. Jaitly on your source of learning about cardiology and human heart. Welcome to MuniMeterHealth, your source of learning cardiology. Welcome all interns, residents and fellows, and of course my dear students. Today in this short video we'll be briefly talking about what is LV smoke. Now I'm going to draw an echocardiographic apical view, if you will, in this fashion. And of course the heart will look like this. It's inverted, as you know, and this becomes your RV and RA. And here is your enlarged left ventricle. I'm schematically showing the left ventricle a little more dilated, if you will. Okay, so just so that you know, so this way we have left ventricle here represented, left atrium here, RA is here, and this happens to be your RV. Okay, so now the left ventricle is profoundly weak. In other words, there is reduced ejection fraction. So this is not only weak, but is also dilated. That's why I'm showing the arrow here. So the left ventricle is much enlarged. Obviously, the mitral valve leaflet is here. Sometimes the mitral valve may be stenosed. So there might be mitral stenosis. LVEF, we call it the ejection fraction, is markedly reduced. It could be 10, it could be 15%, etc., etc. So just so that you know, normal ejection fraction is more than 50-55% by most, textbook criteria. Again, I always refer you back to the textbooks, but just so that you know, here it's profoundly low. So a severely reduced left ventricle ejection fraction is one of the criteria to detect LV smoke. Now, what is LV smoke? LV smoke is a characteristic echocardiographic entity which defines the spontaneous echocardiographic contrast within the left ventricle. So what's happening is there is a whirling of blood that's constantly occurring in the left ventricle. Now you know that left ventricle is supposedly should be ejecting into the aorta every beat if it's a normal LV function, but because it's profoundly low ejection fraction, blood stagnates here, and when it stagnates it just sort of whirls in this direction. Okay, so it keeps whirling within the left ventricle, and the spontaneous echocardiographic contrast, also known as SEC, is generated. Now it could be present in LV, it could be present in LA also. So the same thing can exist here as well, these spontaneous echocardiography. Now the SEC is generated mainly from two reasons. One, the red blood cells, because they are the particles. Obviously they're sending the echocardiographic signals back to the transducer, and therefore one can see it on the screen. And the second is the plasma proteins. So remember that. So plasma proteins and RBCs, these are the two major reasons why SEC occurs. Now amongst the plasma proteins, predominantly it's the fibrinogen. Now you know that fibrinogen is very it's essential part of the coagulation cascade. If you know the factors like the coagulation factors and the fibrinogen and the platelets, they're very involved with coagulation. So fibrinogen has to be present in high amount in order to cause this spontaneous echocardiographic contrast. Now in some individuals where the hematocrit is extremely low, patients who are markedly anemic and they are in heart failure, they may not have SEC present in those patients. Okay, so LV smoke may not be seen. Now we know it's a common, very old saying, where there is smoke there is fire. So obviously wherever there is LV smoke, we call it in quotes here, there is a presence of either a large atrium, there might be a presence of atrial fibrillation, or there might be a previous history of CVA or a TIA, or even a systemic emboli. If systemic emboli has occurred in a recent history or in the past history, then these are very negative connotations from prognosis point of view. Just remember that. So obviously the question arises whether or not to anticoagulate these patients. Now this is determined on an individual basis, and it's a clinical judgment call. I normally say that because American College of Cardiology does not recommend any heart failure patient to be anticoagulated unless and until there is an atrial fibrillation present or some history of atrial fibrillation present, either by a Holter or say by cardiac monitoring, or even by loop recording, or some other mechanisms, or telemetry monitoring on a floor where patients have demonstrated atrial fibrillation for prolonged times, and in a setting where the left ventricular ejection fraction is markedly low, and of course you have LV smoke in the echocardiographic interrogation. So remember, this is an apical view of the in an echo examination, echo study, echo test, and the LV tends to show the spontaneous echocardiographic contrast, where there is a whirling of blood occurring, and the red blood cells as well as the plasma proteins, they reflect back and cause this SEC, or the spontaneous echocardiographic contrast seen on an echo. It has negative connotations, obviously, because the prognosis is bad as a result of it's almost a precursor to coagulation, a coagulant state, if you will, and therefore the need for anticoagulation should be assessed on a case-to-case basis. Remember, if you have contraindications for anticoagulation, like a patient is prone for falls or injuries, like elderly, frail people who are just walking with a cane or a walker, and they tend to, or some people who have a history of swaying because of, so the gait, if the gait is abnormal in these patients, then that could be an issue. Or previous history of bleeds anywhere, whether it's a GI bleed, a neurological bleed, or GI, GU, gastrointestinal, genitourinary, and or neurological. If it is a CNS, any place where somebody has had a significant bleed, that becomes a contraindication for anticoagulation. So obviously, I always say to my students, understand the contraindications first before you decide to anticoagulate, because remember, anticoagulation is extremely it's a chronic process. It's a long, sometimes even a lifelong process. So you don't want to commit a patient with an anticoagulation protocol without knowing what the actual scenario is, and if there is any indication or contraindication existing, etc. So just be sure why you are indicating anticoagulation in these individuals, and that's why ACC reserves the right to the clinical cardiologist, and clearly advises that it should be decided on a case-to-case basis. So you've learned something about LV smoke in this short video. Once again, I welcome you on MuniMeterHealth, your site, and continue learning with us. Remember, it's a total education source only for you to grasp various entities in cardiology. It's not a medical advice channel, so just make a note of it. And if you were to have an emergency, please go to the nearest hospital, dial 911 if you're in the United States, and get to the nearest hospital, nearest doctor, and consult. Okay, and once again, please, if you like this video, do not forget to press the like button. We'll appreciate your questions, your comments, your suggestions at the end of the video, and do drop in a line, and I make it a point to really answer your questions in a very quick period of time. Thank you again, and thanks for watching MuniMeterHealth. So long, and I'll come back and see you on another video now. Bye.